Thank you, Dirk, and thank you once again for inviting me to this meeting. So, if I have can the angiosome concept help in making a decision for BTK endovascular procedures? I mean, we have guidelines who say, with not a very strong recommendation, which is 2P, that the use of the angiosome-directed endovascular therapy may be reasonable in patients with CLI, non-healing wounds, or gangrene. This was in 2006 in the American ones. And the European ones said in one statement, the decision of revascularization should consider the angiosome concept targeting the ischemic tissue, but the angiosome model should not be used as an absolute strategy. The issue for that was because really well-structured prospective studies are needed to assess that. What's the angiosome concept? It's a concept from plastic surgery, which is an anatomical concept, defined as the blood supply from a main, secondary, or distributing artery to a specific tissue area. Why is this angiosome concept so necessary, or why do we look for help to guide us in BTK procedures? Even despite an aggressive approach for revascularization, the amputation rates are up to 20%, and they can also occur in a food with a patent pipe or a good runoff to the food. So this is a patient from our cath lab, really a bad wound situation. He then got a vascular bypass because all the repeat procedures endovascular failed, and that was the end. At the year he had a major amputation anyway. So we always say, okay, if you have different comorbidities in CLI patients, these different comorbidities might be responsible for the different outcomes. But if you have different comorbidities, we almost have comparable amputation-free survival. So there must be something else which is wrong with our concept during the procedures. There is for sure some limitations concerning BTK angioplasty, and we have already heard it today. We have a high rate of repeat endovascular treatment, up to 1 year. We have high rate of restenosis, and we have this issue of early recoiling. So we should consider endovascular revascularization as a strategy providing blood flow efficiently because of the presence of limitations of BTK angioplasty. There is a meta-analysis for this angiosome concept, published 2014, showing this angiosome concept when it comes to direct revascularization, that it's effective in wound healing compared to indirect, and it's also effective in limb salvage. But when we go deeper into the studies, we see that this angiosome-guided angioplasty, the direct angioplasty, is more or less effective depending on different patient characteristics. You see the yellow ones more effective and the blue ones less effective. So what are these factors contributing to if it's less or more effective? For example, renal insufficiency is independently associated with a distal distribution pattern, which is worse. And if you have this diseased artery-artery connection, this is also very often the case in patients with diabetes and dialysis. So we should seek determinants, because there's a discrepancy from theory to practice. We should seek determinants of patients with CLI who derive the most clinical benefit from direct revascularization. Even if you do an indirect, you can have limb salvage. So we have to look what kind of patients we should look for a direct or an indirect revascularization. Are the data out there? Yes. Especially from Japan, Ito has done a lot of work in that. So worse limb prognosis for indirect versus direct is in his first paper, where he able to show that in patients with CLI complicated with wound infection and diabetes. And patients with wound infective and diabetes had a poorer outcome, and indirect revascularization was done, as shown here. And a follow-up paper from his group showed that the angiosome-orientated revascularization for CLI patients without concurrent wound infection and diabetes is not that different with regard to amputation-free survival and freedom from mail. And this is the last paper from Spilero, published last year, that he was able to show in his study that the angiosome target PTA is more important in patients with diabetes. In diabetic patients, indirect endovascular revascularization leads to the poorest wound healing and lag salvage rates. So endovascular procedures should be targeted according to the angiosome concept. I want to conclude when to think about the angiosome concept. Red, I see a necessity. Blue, I see less necessity. If we have diabetes and infection, I think then we really should go for the angiosome concept, as we have data so far underlining that. If we have infection, we should also focus on the angiosome concept. If we have a diabetes patient, once again. In non-diabetes patients without any infection, it might be not that relevant. Thank you very much.